Johari is a senior consulting ophthalmic surgeon practicing in Mumbai. She has been president of BOA in the past and is executive committee member of several organizations. The cause of children with cerebral palsy and multiple disabilities is very close to her heart. She is very passionate about this subject. She will be talking to us about common eye problems in children with cerebral palsy. Dr. Usha Johari, the screen is all yours. So you can share your screen and start.
Yeah. Thank you very much. Okay. Can you hear me? Yeah.
Yes, ma'am, we can hear you.
Yeah. Okay. A very good evening to all of you, and thank you ISCP for organizing such a wonderful webinar and making me a part of this webinar. So let me start saying that what we see in fact is made in the brain from signals given to it by the eyes. So what cerebral palsy means to ophthalmologists is something which is still a niche. And so I would describe cerebral palsy. Yeah. I would describe cerebral palsy as a disorder of movement and posture resulting from permanent non-progressive defect or lesions of immature brain. So this we see in the form of monoplegia, diplegia, hemiplegia, or quadriplegia, and this is related to the description of the limb and the limbs only. Now, the classification of cerebral palsy for the physiotherapist and for the pediatricians, I think it's very well known. But from the ophthalmologist point of view, I've classified, the classification is very simple. The spastic variety, which involves, pyramidal tract, and 60% of these lesions dominate in the cerebral palsy, which is where the muscle is involved. And the second type is the dyskinetic type, which is comprises of 35%, which is extrapyramidal in nature, where the posture is involved. And the third type is the rare type, the ataxic type, which is a cerebellar type, where it involves the balance system. Now, the incidence of cerebral palsy, as Dr. Lahane previously mentioned, is nobody is very sure about the incidence. But what I have gathered from the statistics is the occurrence is 1 to 2 per 1,000 population because of different etiology. The commonest cause is the perinatal brain damage. Now, the incidence of premature birth is increasing. We have excellent neonatologists who are taking very good care of these children. And that's exactly the reason the incidence of cerebral palsy is increasing. The latest statistics say that there is 1 in 278 children having cerebral palsy. Now, from the ophthalmologist's point of view, why cerebral palsy is important? Of course, we all understand that the poet says that the eye is a window to the soul. But as an ophthalmologist, I would say that the eye is a portal to the brain, window and the tail of the brain. It's surprising to know that the 60% of the human brain has visual activity, and Nakoyama, way back in 2012, also mentioned that 40% of the brain helps in supporting and processing vision. So another surprise is that human eye has almost 2 million working parts. Now, the ophthalmic peculiarity in cerebral palsy is nothing new to us. It's been known over a century. But why has this visual disability been there in these children? Because of ignorance. It's been overlooked. There's a lot of social stigma, lack of education, and lack of economics in our scenario. And most of the parents always feel that the child should be, the extremity should be first taken care of, and eye comes to them at the end. If the general pediatricians recognize cerebral palsy around the age of 80 months, We as ophthalmologists know very well that the eye fixation takes place at 3 months, binocular single vision fusion and stereopsis takes place at 7 years of age. Then why is this late detection? The visual difficulties, normally the child that has in cerebral palsy is, from the parents' point of view, is sometimes the parents wonder whether the child can see, number one, number two, whether the child can react to the light, or does the child, after reacting to the light, has a fixed visual attention, and does the child react to the noises which are not visual, and of course the fixation and the head posture, and does the child pursue with the moving objects. And you'll all agree with me that mother is the first eye doctor for a cerebral palsy child. Now, attention to the parents. Mother being the first target, it's the child sees the mother's face. The parents normally complain that the child may blink excessively or may not blink at all and keeps gazing at the light and always prefers a bright color, which is a moving object, and turns the head away from the object. So indirectly, the child is using the peripheral vision. And most of the relatives, friends, the child, where the child is moving, they all feel that, is this child a slow child? Now, the visual difficulties from the cerebral palsy from the child's point of view is the child does not have any problem at all, because the child feels the child is seeing what the other children are seeing, and the child is very happy in his or her own world. And this realization comes very late, and the other problem the child has is the child has difficulty in remembering things that they have seen. And of course, as they grow, they have tired vision and reading difficulty. Now, as an ophthalmologist, what we face is a fall in the visual acuity, fall in the sharpness of vision, field loss. Child has difficulty in focusing near objects, recognizing objects, keeping the fixation still on an object, and they have difficulty in using vision to move parts of their body around. Now, the incidence of cerebral palsy in visual loss in cerebral palsy is both brain related, eye related, could be either of them. And in our study where we carried out, we found that 91% of the children had eye problems compared to Peter Black, who had only 80% of the children having eye problems. Another interesting thing that was noticed was that a child with cerebral palsy has multiple eye problems. It's not just one problem. So how can this be incidental? And can we make a difference to the lives of many children and families and maximize their visual potential? And of course, we can do it. So basically, we all know that the visual system in an infant and children is dynamic and very sensitive. So for better understanding, I have classified the problems into reversible, partially reversible, and irreversible, where reversible and partially reversible need a regular checkup and early detection because they're almost 100% correctable. Whereas the irreversible, we take the help of the visual rehabilitation specialist. Now, the reversible ones are commonest ones are the squint, refractive error, and cataract. And we need to give a special attention to accommodative disorders and anisoconia. And as the child grows, the refractive error keeps changing. So not to forget the annual checkup. And early detection is, of course, mandatory. Now, you'll all agree with me that a normal child who is a hyperope, as the child grows, reduces, whereas in a child with cerebral palsy, it's retained. Astigmatism also is retained in a child with cerebral palsy. Accommodative disorders, which are very important, which normally occurs in the middle age, appears very early in childhood. And myopia and anisometropia, of course, increases with age, both in a normal child and in a child with cerebral palsy. So the high prevalence of refractive error is very common in child with cerebral palsy. Now, what we mean by accommodation disorder is the difficulty in focusing the near objects. So the child, this accommodation occurs not only just because of the eyes, but it is within and beyond the eye because there is a reflex, or it's an automatic reflex which is complex right from the brain to the eye. Now, the spectacle therapy, imagine a child having impaired mobility, impaired communication, and over and above that, an impaired vision. So we do have special glasses for children, which could be progressive, bifocal, short curved sidearms with the shatterproof glasses. And a spectacle therapy is extremely important because we know that if we treat this child at an early age, the child can have the best visual outcome. And of course, the child is the best judge. The child, of course, realizes the difference when they see the objects around them. Now, the eye movement disorders in children with cerebral palsy is proportionate to the degree of cortical visual impairment. In general population, the squint is normally 3%, whereas in a child with cerebral palsy, it is 46%. Why this difference? Because in cerebral palsy, the squint is not only because of refractive error or the muscle imbalance, but it could be because of the lesions in the subcortical, oculomotor, and the cerebellar area. These are the few children who have got the divergent squint and convergent squint, and they've been treated. And a word of usage of Botox in certain cases. And amongst the ophthalmologists, we have 4 popular O's: the optical treatment, occlusion, orthoptic, and the operation. Now, developmental cataract, the causes could be maternal infection or malnutrition, which is a non-progressive white opacity in the pupillary area. And of course, the treatment for this condition is surgery. Now, coming to the partially reversible or partially treatable cases, which is amblyopia, retinopathy of prematurity, and the postural abnormalities of the trunk and the neck. Amblyopia, we all know, in this condition, we always say that prevention is better than cure, because there is a partial loss of sight either in one eye or both eyes, and there are absolutely no objective signs and no ophthalmoscopic findings. So this is how we treat amblyopia. And aggressive treatment, normally less than 7 years of age, because that's the period which is the end of the sensitive time. Retinopathy of prematurity, which is very common in low birth weight children. Most of the time, no treatment is required. But in 10% of the children who go blind, it has to be detected early. It has to be detected at a very early stage. And there are 5 stages: mild, moderate, and severe, where the vessels are mildly abnormal, moderately abnormal, and severely abnormal. And in the stage 4, where we see a partially detached retina, and stage 5, which is the last stage, which gives rise to a complete retinal detachment. Now, the eye and the posture abnormalities in cerebral palsy, for example, torticollis, it is because of the retrochiasmatic damage of the visual system, which I have shown it with an arrow. And these children also have to be treated accordingly, either with an orthopedic surgeon who treats the thoracic abnormality and the torticollis, and we as ophthalmologists treat the eye problems. Now, the non-treatable or the irreversible causes are nystagmus, optic atrophy, birth defects, fixation loss, and the most important, cortical visual impairment. And we have with us the father of cortical visual impairment, Dr. Tatan, who will be talking on cortical visual impairment. So the next thing is the nystagmus, where we see that there is a periventricular damage, which could be either pendular, where the movement is in harmony, and it could be a jerky, where there is movement quick in one direction and slow in the other direction. We all know that the optic nerve is the tail of the brain, and see how healthy the normal optic disc looks compared to a case with an optic atrophy, which is a pale white disc. An optic nerve carries almost 1 million nerves from retina to the occipital row. Now, these are the few birth defects in the eye. There's no eyes, which is called as anophthalmos. The coloboma of the eye, which is the iris, which is a pear-shaped iris. Microphthalmos, you can see that one eye is smaller than the other. Then the disease of the retina, which is called as a retinitis pigmentosa, where you can see the bony-like corpuscles at the periphery, and the normal field and the tubular field, which is very common in retinitis pigmentosa. Now, cortical visual impairment, just if it is a lesion between the lateral geniculate body and the visual cortex, there is a fall of vision and the ocular findings are normal. And of course, when there is such a gross cortical visual impairment in this child, spectacle therapy would be inappropriate. And we see a slide of periventricular mucomalacia, which helps us in rehabilitation and diagnosis depending on the area of periventricular malacia. So there is a breakdown in communication between the eyes and the brain. Now, the visual brain, which has the dorsal system and the ventral system, the dorsal system helps us to move in space. And when there's a damage to this system, the child has a difficulty in getting down the stairs, walking sidewards, forwards, and even to grab a drink. whereas a damage to the ventral system, the child has difficulty to recognize space and the objects and the places. Now, the saccades normally in a normal person, there's a quick change in the direction and the eye can follow accurately on a fast moving objects, which does not happen in a child with cortical visual impairment. Now, the questions to be answered is, can cerebral palsy be detected in pregnancy, and is cerebral palsy hereditary? So it is not that, we alone can do anything. It is the ophthalmologist with all this, consultants, physicians, all the specialties which are mentioned here. We all have to work together to see that this child can, can be independent. And the important role is of the parents and teachers and the caretakers. Now, so in my opinion, cerebral palsy still remains a mysterious entity. It's, of course, a very difficult, uncertain, with a lot of associated problems. And as I previously mentioned, there is impaired mobility, impaired communication, learning difficulties, and above all, impaired vision. So I would conclude saying that let's not say nothing can be done. Let's suspect, detect at an early age, and correct. And this is what, in my opinion, is the role of the eye surgeons in cerebral palsy. Thank you very much.
Thank you, Dr. Usha. Indeed a mysterious disease, and I hope that today's seminar clears some mysteries out of this disease.